I'm Safwan, fourth year medical student. I will explain the thalassemia. Okay, first of all, what is thalassemia? It's an inherited disorders characterized by reduced production of either alpha or beta globin chains of hemoglobin. As you know, hemoglobin is formed by four globin chains. If there is any abnormalities in the production of alpha or beta, then this is called thalassemia. Okay, before we start, I will give you an overview about the hemoglobin that is normally present in any normal adult. First of all, hemoglobin A. Hemoglobin A is formed by two alpha subunits and two beta subunits, and it's 97% of the adult hemoglobin. So this is the most dominant type of hemoglobin in any normal adult. Then we have hemoglobin A2. It's two alpha units and two delta subunits. It's 2% of the adult hemoglobin, and we see an increase in beta thalassemia, and we will explain it more, inshallah. Then lastly, we have hemoglobin F. This is like two subunits of alpha subunits and two subunits of gamma. It's normal in fetus, but we can find it in less than 1% of adult hemoglobin. We will start with beta thalassemia. It's more prevalent in Mediterranean area. What is Mediterranean area? It's like منطقة البحر الأبيض المتوسط, like Syria, Lebanon, Italy, Greece, the south of Turkey. These areas are the most prevalent areas with beta thalassemia. It's an important information for your exams. The mutation here is point mutations. On chromosome 11. Chromosome 11 have two genes for beta thalassemia. If one of the gene or both of them are reduced, they can be reduced in production or they can be absent. So if they have two gene mutations, both of them are absent, which means the patient have no beta units synthesized. So this is called beta thalassemia major. But if they have the reduction in the production of the both subunit of the both genes, or one of them is reduced and one of them is absent, then this is called beta thalassemia intermedia, which means the patients still have some beta units synthesized, unlike the major. Then lastly, we have the most we have the beta thalassemia minor. Like one is normal, and the one of the genes either reduced in production or absent in production, and this is the milder form of all the thalassemia type. Okay, first of all, we will start explaining the beta thalassemia minor. They are asymptomatic, or they can have mild microcytic hypochromic anemia. And because of that, most of the doctors can misdiagnose it as iron deficiency anemia. So whenever you have a patient presenting with microcytic hypochromic anemia, it's important to order iron studies. So first of all, when a patient presents with signs of mild anemia, first of all, we have a CBC. In CBC, we will find a reduced MCV and MCH. So this is microcytic hypochromic anemia. There is a mild increase in red cell counts and mild anemia. When we say mild anemia, we mean that the hemoglobin is between 10 to 12. So this is mild. And the RDW is normal or a slightly increased. RDW can help you differentiate between iron deficiency anemia and beta thalassemia, because RDW is increased in iron deficiency anemia. So this is something you can differentiate from the CBC. Then you should order iron studies. Why? Because we want to differentiate it between the iron deficiency anemia and it's normal. It would be normal. Then lastly, we will order hemoglobin electrophoresis. In hemoglobin electrophoresis, there's a characteristic finding, which is increase in hemoglobin A2 more than 3.5%. As we said before, its normally should be 2%. So if it is more than 3.5%, then this confirms the diagnosis of the findings that we found in CBC and iron study, and then we can diagnose the patient with beta thalassemia minor. Beta thalassemia minor, unfortunately, has no treatment other than reassurance and patients' educations. You can't give them anything to help them, and they mostly asymptomatic, so no need for treatment. Then we have the beta thalassemia intermedia. Intermedia has a moderate severity of anemia. The hemoglobin would be between 7 to 10, which is more severe than the minor. We diagnose it as well with hemoglobin electrophoresis, but here the difference between minor and intermediate, that there's increase in the level of hemoglobin F. And the peripheral blood smear will show microcytic hypochromic RBCs, similar to the minor. And most of individuals are non-transfusion dependent, unlike the major that we will talk about it in a minute. They are non-transfusion dependent, but maybe in adulthood they might need transfusion. Okay, now we will move to the beta thalassemia major. It's like 1 out of 4 offsprings of two thalassemia minor carriers patient. That's why the patient education for beta thalassemia minor patients is important, because if they have to marry another beta thalassemia minor, they can have the risk of having 1 out of 4 of their children to have beta thalassemia major. And what are the clinical pictures that the patient have? A severe anemia that starts at 3 to 6 months of age. Why? Because here is the time where the hemoglobin F will decline and hemoglobin A for the adult will take place. But as we talked before, the hemoglobin A in the adult have 2 beta subunits, and in this patient they can generate beta subunits. So they will have these symptoms be apparent in this age. What are the symptoms? Because of this, because they can generate beta subunits, so the alpha subunits will cluster together and cause a toxicity of the RBCs and cause their destruction. So they will have hemolytic anemia that can present with jaundice and dark urine, and also massive hepatosplenomegaly. Why? It's because of 3 causes. Because the excessive red blood cells destruction, because the spleen will detect this abnormally RBCs that have the abnormal hemoglobin and destruct it. So they will have increase in this function. So they will be enlarged. And for the extramedullary hemopoiesis, because the body tried to compensate for this anemia to increase the production, and spleen and liver are from the size that can generate RBCs. And also iron overload, either by transfusion or by the increased hemolysis. When there is any hemolysis of the RBCs, there is a part of hemoglobin that is iron. Iron will accumulate in the body and can accumulate into the spleen and liver and cause their enlargement. And also the expansion of the bones, because the bone marrow is expanding to compensate for the anemia to increase the production. So they have a characteristic face. It's called the thalassemic face. As you see here, the patient have prominent facial bones. This is a characteristic. And also we have hair on end appearance on the skull x-ray, as you see here. This is like small hairs. This is characteristic for beta thalassemia major, and they would have growth retardation and failure to thrive. And if you left the patient untreated without any transfusion, they will die within first few years of progressive congestive heart failure. Why congestive heart failure? Because of the chronic anemia, severe anemia. The heart will increase, the workload on the heart will increase because it will try to compensate by increasing cardiac output. Then the muscle will be hypertrophy, and it won't be filled with the blood or pumped efficiently. So the patient will die of the complications of congestive heart failure. Then an important point that the patient will have an increased risk of parvovirus B90 induced aplastic crisis. Okay, how do we diagnose? First of all, if a young patient, present to you with severe anemia and presentation of hemolytic jaundice and all the signs that we described before, we order a CBC. We will find an MCV reduced and MCH reduced, and also you will find a really reduced hemoglobin levels. Then you will go for hemoglobin electrophoresis. It will reveal an elevated hemoglobin F and hemoglobin A2. This is what hemoglobin electrophoresis looks like. As you see in the normal, as we described before, the majority of the hemoglobin will be hemoglobin A, and hemoglobin F is like less than 1%, hemoglobin A2 is 2%. And in thalassemia trait, hemoglobin A is also here is the majority of hemoglobin, and we have a slight increase in hemoglobin A2. While in major, most of the hemoglobin is hemoglobin F and hemoglobin A2. So this is characteristic for beta thalassemia major. And when we do peripheral blood smear, it reveals microcytic hypochromic anemia and characteristic finding for beta thalassemia, which is target cell. This is the target cell. It's like it's similar to the target. The center is dark and surrounded by a pale circle. What is the treatment? The treatment for the patient, you will do a frequent packed RBCs transfusion. Our goal is to keep the hemoglobin above 10 to sustain the patient life. But if you are doing a frequent RBCs transfusion, then the patient have a risk for iron overload, because if you give like 2 bags or 1 bag of RBCs, you are giving the patient an iron that is equal to 1 to 2 years iron intake. So the patient can because the patient can have complications. So you should give them, together with the transfusions, iron chelating agents. The most common one is disopyramide, because to prevent iron overload because of the repeated transfusion that cause hemosiderosis that can lead to accumulation or severe damage to endocrine glands, liver, pancreas, and myocardium. And we have also another option, which is the splenomegaly, because the spleen is, when we remove it, we can reduce the destruction of RBCs and relieve some of the patient's symptoms and signs. But this is usually should be delayed until the age of 6 years for the risk of infection, because spleen is important in immunity. This is an interesting fact that both sickle cell trait and thalassemia, mainly beta thalassemia, are protective against malaria infections, especially Plasmodium falciparum. Okay, now I have this question. I hope you can get it right. A 17-year-old Syrian female presented with a complaint of palpitation, fatigue, weakness. Her physical examination revealed mild pallor. Her CBC showed hemoglobin of 10.5, MCV reduced, MCH reduced, normal RDW, mild increase in RBCs. Her iron studies are normal. Peripheral smear shows microcytic hypochromic erythrocytes and showed target cells. Hemoglobin electrophoresis was done and showed increase in hemoglobin A2, normal hemoglobin A, hemoglobin F. What is the proper management? Iron supplement or reassurance or blood transfusion with iron chelating therapy or bone marrow transplantation? What do you think?
Reassurance.
Yes, right.
Because it's a beta minor.
Yes. Okay, now lastly we have alpha thalassemia. Alpha thalassemia is more common in Far East. Here the mutation, before we discuss the mutation, the alpha globin has 4 genes on chromosome 16, unlike beta unit had 2 genes. So the alpha globin gene, the mutation will be deletion that will lead to reduced synthesis. So you have, you can have 1 gene deletion, then we call alpha thalassemia minima. The patients here are asymptomatic and have no signs, and it's rarely detected because they are silent carriers. Then if we have 2 gene deletion, then this is thalassemia minor. They have just a mild microcytic hypochromic anemia, and it's so milder than beta thalassemia because they still have 2 intact genes that can synthesize the alpha subunits for them. If they have 3 genes deletions, this disease would be called hemoglobin H disease. Here in this patient, you will find a type of hemoglobin called hemoglobin H. Hemoglobin H is a hemoglobin with 4 beta subunits. What are the symptoms or signs? They have moderate to severe microcytic hypochromic anemia, but they are not transfusion dependent. But sometimes they will require periodic transfusions during episode of increased hemolysis, like in infections. Lastly, we have 4 gene deletions. Here, they have a hemoglobin type called BARTs. This hemoglobin BART is for gamma subunits, and this hemoglobin is useless because it cannot carry any oxygen. So the babies who have this mutation will either die at birth or shortly after birth. And if they die at birth, we call them hydros vitalis. Okay, lastly, I have a question about aphathalassemia. A 3 years old child of Southeast Asia descent presented with symptoms of chronic anemia, including blood fatigue. Labs investigation revealed a moderate microcytic hypochromic anemia. Hemoglobin electrophoresis shows elevated level of hemoglobin H. What are the subunits hemoglobin H composed of, and how many genes deletion in alpha globin genes the patient has? What do you think? Yes, C, that's correct. The hemoglobin H is composed of 4 subunits of beta, and they have 3 gene deletions. Okay, I'm done with the part of thalassemia. Thank you. Do you have any questions? Okay, I think Katrina can start.
Hello everyone, I'm Qatrinada and I will explain sickle cell diseases. So what's sickle cell diseases? It's a autosomal recessive mutation leading to presence of hemoglobin S instead of hemoglobin A, which is the normal one, produced by replacing the glutamic acid uh, by the valine in the beta chain. Also, in the sickle cell anemia, the hemoglobin A2 and hemoglobin F will still produce as a compensatory mechanism. Sickle cell diseases predominant in individual of African and Eastern Mediterranean descent, and also can present in any person from any ethnicity. Sickle cell diseases the most common form of intrinsic hemolytic anemia worldwide. For its type, we have two. The first one, the sickle cell anemia, when the 2 copy of hemoglobin beta chain mutated, and the second, which is the sickle cell trait, when 1 copy of the hemoglobin beta chain mutated. For the precipitating factor and pathogenesis, sickling occur when the deoxygenation of hemoglobin S, leading to aggregation and form polymers, so leading to the sickle appearance and become more rigid. There are some factors trigger the sickling and um, leading to more sickling, which is the precipitating factor, either due to decreasing in hemoglobin affinity for oxygen, vasoconstriction, or increased concentration of hemoglobin S in the blood, like in the cases of hypoxia and acidosis, infection and fever, dehydration, cold temperature, stress, and pregnancy. For the clinical picture depends on the hemoglobin chain combination. So we have 3. The first one, the sickle cell anemia, will produce the most severe clinical picture or symptoms and signs. The second, which is the combination heterogeneity, hemoglobin S and C, will lead to intermediate symptoms. And the third, which is the sickle cell trait, have no symptoms or reduced symptoms in the cases of severe trigger or precipitating factor. Clinical picture caused by two mechanisms. The first one, reduced RBC survival, either extravascular hemolysis, when the macrophages of the spleen phagocytose the abnormal RBCs, or intravascular hemolysis, when due to weak cell membrane of RBCs lead to its destruction in the blood vessels. So the decrease in RBC survival lead to anemia. The second, which is the tendency of sickle cell to aggregate and cause vaso-occlusion, as the sickle cell have more adhesion molecule and lack of elasticity, lead to occlusion of microcirculation and tissue infarction. So mostly the manifestation will present after 3 to 6 months of age, as the hemoglobin S increase instead of hemoglobin A, and decrease in the hemoglobin F level. So approximately 30% of the symptoms develop in the first year of the life. For the classic presentation, the patient will present with sudden onset of severe chest pain, back pain, or thigh pain, and may be accompanied by fever. As it's the classic manifestation of vaso-occlusive crisis, I will explain in the next slide. In childhood, the dactylitis may be the first presentation, and most of the cases present at the age of 6. So we will classify the manifestation to acute and the chronic manifestation. The first one, which is the vaso-occlusive events, or it's called acute painful vaso-occlusive crisis. The patient will present with moderate to severe pain. The pain can be from any side of the body, but frequently will be from chest pain, back pain, thigh pain, and accompanied by the fever. For the dactylitis, will occur in less than 3 years of old, and the patient will present with severe pain and swelling of the both hand and feet. If the occlusion occur in the mesenteric vessels, will lead to mesenteric ischemia. So the patient will present with acute abdominal pain, mimic acute abdomen. If the occlusion occur in the CNS, leading to CNS infarction, leading to stroke, cognitive defect, and seizure. Also, the patient may present with priapism, avascular necrosis of the femoral head, or leading to ischemia leading to organ damage, like in the splenic infarction, leading to autosplenectomy, and mostly occur in the patient less than 2-year-old. The next, which is if the sickling occur in the renal medulla, leading to renal papillary necrosis, the patient may present with hematuria, hypostenuria, which is the decreased ability to concentrate urine, also presenting with polyuria or nectaruria. If it affects the eye, will lead to proliferative retinopathy. For acute chest syndrome maybe occur due to occur in 3 mechanisms. The first one, which is hypoxia due to vaso-occlusive crisis. The second, which is fat emboli from the bones due to also the vaso-occlusive crisis. And the third, which is infection due to the autosplenectomy. So the patient will present with pain, fever with cough, tachypnea, and respiratory distress, accompanied by pulmonary infiltrate, involve the complete lung segment on chest radiography. So in the cases of splenic infarction leading to autosplenectomy, the infection tendency will be higher, and autosplenectomy makes the patient susceptible to encapsulated bacteria. So the most common bacteria is Streptococcus pneumonia, leading to sepsis. Also, the patient may present with meningitis, osteomyelitis due to Staphylococcus aureus, and pneumonia, in addition to acute chest syndrome. For acute hemolytic crisis, the patient either present with splenic sequestration or aplastic crisis. Splenic sequestration, which is when the blood trapped in the spleen due to vaso-occlusion of vessel leading out of the spleen. So the patient will present with painful enlarged spleen. For the aplastic crisis, it's occurred due to suppression of bone marrow due to paravirus B19 infection. In the two cases, the patient will present with the sudden drop in hemoglobin level. So we can differentiate between them by the level of reticulocytes. In the splenic sequestration, the patient will have normal or high reticulocytes, while in the aplastic crisis, the patient will be decreased level of reticulocytes. For the chronic manifestation, mostly will present as anemia due to hemolysis. Also, the patient have jaundice, pigmented cholelithiasis, increased cardiac output leading to murmur and congestive heart failure, and may lead to delayed growth. Also, the patient may present with chronic pain. For sickle cell trait, it's a benign condition and doesn't cause symptoms. Also be protected from Plasmodium falciparum malaria. The patient CBC and peripheral blood smear doesn't show any abnormality. Some cases present with renal complication like hematuria if the renal papillary necrosis occur, defect in the ability to concentrate urine, and increase risk of UTI. For diagnosis and treatment, we'll start with the diagnosis. The best initial test, the CBC and peripheral blood smear. So in the CBC will show increased reticulocytes and indirect bilirubin, and the hemoglobin level will be ranged from 6 to 8 gram per deciliter. And the peripheral blood smear will show 3 changes. The first one, which is sickle cell, which is always be seen, and holy jolly bodies due to autosplenectomy, and the target cells, as we see here. For the most accurate test is the hemoglobin electrophoresis. So electrophoresis will show, as we see here, the normal electrophoresis. The most the higher level is hemoglobin A. Also, the hemoglobin F and hemoglobin A2 will present. So in the sickle cell anemia, the higher level for the hemoglobin S and the hemoglobin A will be absent. And as I said before, the hemoglobin F and hemoglobin A will be present, but the hemoglobin F will be increased than normal. And in the sickle cell trait, the hemoglobin S will be present and the hemoglobin A will be present. Because of that, the symptoms will don't appear, and the hemoglobin F and hemoglobin A also will be present. For the other tests, we have the first one, sickle solubility test, when we mix the hemoglobin S and the reducing solution, leading to turbulent appearance due to precipitating of hemoglobin S. The second, which is skull X-ray, will show clear-cut appearance. Here for the treatment, it's the sickle cell anemia is not curable disease. So we have to prevent the symptoms by prophylaxis, avoiding precipitating factor. Also, if the crisis occurred, we have to manage the symptoms by rehydration, warmth, and analgesia. Also, we can use hydroxyurea, which is increase the hemoglobin F concentration, leading or prevent the sickling. Here for the MCQs. A 35-year-old African American man with sickle cell anemia is admitted to the hospital because of fever, chill, and malaise. His WBC's count to 24,000 with 1,500 15 bands, 80% neutrophil, and 5% lymphocytes. He quickly became hypotensive and died, despite aggressive resuscitation. His blood culture are most likely to grow which of the following organism? Staphylococcus aureus, Streptococcus pyogenes, Streptococcus pneumonia, virident streptococci. Mhm. Yes, it's C. As it, the most common of, as we see here, the case is sepsis. So the most common cause of sepsis is Streptococcus pneumonia. The second is a 12-year-old African American male is brought to the emergency room with high fever, chest pain, and dyspnea. His past medical history is significant for top prior hospitalization for abdominal pain, which resolved with analgesics and hydration. Evaluation today revealed a hematocrit of 23% and reticulocyte count of 9%. Several hours after being admitted, the patient died in the hospital. At otoscopy, the patient's spleen is firmed and brown. This finding is most likely related to work hypertrophy, follicular hyperplasia, pressure atrophy, and vascular occlusion.
Vascular occlusion.
Yes. The third question: which of the following is true? Of sickle cell anemia in adults? The usual hemoglobin level in adults is 100, 130. Stroke is a major cause of death. The spleen is usually enlarged. Alpha thalassemia trait aggravate the anemia. Iron deficiency often coexists.
Maybe C and A.
No, it's B. Okay, for the next question and the last one, which of the following complications occur frequently in sickle cell anemia? Aplastic crisis, chest syndrome, splenic pooling of blood, bone infarction, and stroke. You can't choose more than one. It's all of them. Yes. Thank you.